Hi, I'm Kathryn Gray. Thanks so much for inviting me today to talk about COVID in pregnancy. Here's our current evidence and recommendations. I have no relevant conflicts of interest, and I do want to acknowledge the significant collaboration with Dr. Andrea Edlow in this work, and many of these slides are her contributions as well. So the objectives of this talk today will be to understand the maternal risks of SARS-CoV-2 infection in pregnancy, understand the fetal risks of SARS-CoV-2 infection in pregnancy, and describe the immunogenicity of the COVID-19 mRNA vaccines in pregnant and lactating individuals. So this is how COVID and SARS-CoV-2 infection has looked in the United States over the course of the pandemic. And here we are in October of 2021. We've had 44 million cases and almost 250,000 deaths. In pregnancy, the trends have mirrored that of the general population, now with 128,000 reported cases and 180 deaths. And 22,000 pregnant women have been hospitalized. Now, what are the risks of COVID in pregnancy? Well, pregnant individuals who get COVID during pregnancy are at risk for severe maternal morbidity and mortality. They're more likely than age-matched similar individuals to need admission to the ICU, require ventilation, need ECMO, and die. And although pregnancy is associated with an increased risk for severe illness, placental infection and vertical transmission to the fetus is actually rare. So when placentas have been examined from pregnant individuals who have had SARS-CoV-2 infection during pregnancy, it's been very rare to find true placental infection. And in terms of fetuses or newborns being infected at birth, the rates are estimated to be only 1 to 3%. And in our series of local hospitals and newborns born to positive mothers, we have documented no infections. Why is this the case? So when we look in pregnancy and look at viremia or SARS-CoV-2 in the bloodstream, there's a very low incidence of detectable virus in the maternal bloodstream in pregnant individuals relative to non-pregnant. Now, in hospitalized non-pregnant patients with viremia, we have seen, and this is the work of the Lee lab, that there is a very high viral load in nasal and sputum swabs from positive patients, as well as some positives in the urine and plasma, but it's certainly not all patients. And the ones who have higher viral loads in their plasma have more severe disease. And so plasma viremia is directly associated with disease severity, and those who are hospitalized are way more likely to have positive viral loads. Now, when we looked in our individuals who were collected at the Mass General and the Brigham and Women's Hospital, we found no detectable viremia in the maternal or the cord blood. So when we examined in the initial part of the pandemic, 64 cases, there was no maternal viremia, there was no viremia in the cord blood, and we saw no infected placentas. So the only types of specimens that were positive that were those from the nasal and oral cavities. The maternal disease severity was significantly associated with the detectable respiratory viral load, as well as some other laboratory studies. Now, in thinking about why SARS-CoV-2 might not infect the placenta, it's important to understand how SARS-CoV-2 gets into cells. So ACE2, or the angiotensin converting enzyme 2 receptor, serves as the entry receptor for SARS-CoV-2 into the cell. And co-expression of the transmembrane protease serine-2 or TMPRSS2 is required for infection of the tissues. So when we look at placentas to see what the expression of ACE2 and TMPRSS2 is, we do see that placentas have high expression of ACE2, and this is largely localized to the syncytial trophoblast and the cytotrophoblast. And when people have looked in the placenta pre-pandemic, they looked in single cells to see if ACE2 and TMPRSS2 were expressed in the same cells, and they really were not. So they were in physically distinct locations. Also, the expression of TMPRSS2 is quite low in the placenta. And in subsequent work, you can see that when gene expression of these two genes is performed in the placenta, there is quite low levels of TMPRSS2 relative to ACE2. So this might explain some of the reasons why the placenta is not likely to be infected. Now, on the other side of things, people ask, if the mother had SARS-CoV-2 infection, is the fetus provided with some protection by the mom having been infected? So we know that maternal IgG antibodies are able to transfer through the placenta into the neonatal blood and are found in cord blood. And for vaccinatable pathogens like influenza and pertussis, the ratio of the maternal antibody level to the cord blood level is typically 1.5 or greater, the cord maternal transfer ratio. Lower ratios have been noted for other infections, such as maternal dengue or Zika. So when we looked to see what the cord maternal ratio was for SARS-CoV-2 antibodies, we found that there was significantly reduced transplacental transfer of these antibodies when mothers were infected in the third trimester compared to the flu. So we saw that the cord maternal ratio for SARS-CoV-2 was about 0.74, whereas for influenza, it was 1.44. So even when the mother has had SARS-CoV-2 infection, there is compromised transfer of the antibodies to the cord, especially when the mother is infected in the third trimester. So the fetus doesn't necessarily get as much protection as you might hope, but there are antibodies that do cross. And why is this antibody transfer compromised? When we looked further, and this is a collaboration with the Alter Lab and Caroline Ateo in the Alter Lab performed a lot of this work, and we looked at glycosylation of the antibodies. It seemed like the glycosylation pattern may have altered the ability of the antibodies to be transferred through the placenta. Interestingly, when we looked at the types of antibodies that were transferred, it seems like the very effective antibodies that had NK cell activating potential were the ones that were actually transferred. So that's a compensatory mechanism potentially to provide fetal protection despite the lower amount of antibodies transferred. Now, in this work, we also demonstrated that if the mother had COVID in the second trimester, the transfer was improved compared to the third trimester. So it also appears that increased time since infection helps with antibody transfer. So in summary, the key determinants of the antibody transfer across the placenta seem to be the time elapsed since the infection, the level of maternal antibodies in her own blood, as well as potentially the severity of the infection that the mother had, although there have been conflicting results about this. So in summary of COVID during pregnancy or SARS-CoV-2 infection, pregnancy is definitely associated with an increased risk for severe morbidity and mortality. Placental infection vertical transmission is rare, likely due to low rates of maternal viremia and a protective pattern of the entry receptors in the placenta necessary for SARS-CoV-2 infection. And the neonatal protection, while antibodies are transferred to the neonate, it's less than might be expected, and that is likely due to the glycosylation profile of the antibodies and the time since the infection. Now, starting in December of 2020, the vaccine became available first to healthcare workers and then to the larger population. There's many different vaccine platforms for COVID-19, and the ones that were first prevalent in the United States were the Pfizer and Moderna mRNA vaccines. And then the viral vector Johnson & Johnson vaccine also became more widely available. Now, as of October 2021, 57% of the United States population has been fully vaccinated. And you can see here the statistics by age group. As of today, children less than 12 years old have not been authorized to be vaccinated yet. So it's only for 12 and up. And you can see that the highest rate of vaccination is in the oldest population, greater than 65 years of age. Now, disappointingly, but perhaps not surprisingly, pregnant individuals have a lower rate of vaccination than the general adult population in the United States. And here you can see across time, from the time when adults first started to become vaccinated through April, when more adults started to be vaccinated and eligible in the United States, up into October, there's been a steadily increasing rate of vaccination of pregnant individuals. It wasn't until the very end of July of this year that COVID vaccination in pregnancy was fully recommended by the CDC, ACOG, and SMFM. Prior to that, it had been have a discussion with your health provider. And you can see here that the data suggests that there is great racial and ethnic disparity by vaccination rate in pregnancy. So for all pregnant individuals as of October 2021, there's about 34% vaccination rate, much lower than its other adults, with definite disparities by race and ethnicity, with the Asian population having the highest rate at 48% and the Black population having the lowest at 18%. So why have pregnant individuals been slower to receive vaccination? Well, when the vaccine was first released in December of 2020, there was no data in pregnancy or lactation. In fact, pregnant and lactating individuals have been completely excluded from the vaccine trials. And so at our Mass General and Brigham biorepositories in pregnancy, we quickly started a protocol where we enrolled pregnant individuals. This was primarily healthcare workers when the vaccines were first released, who were undergoing COVID-19 vaccination, and collected blood from pregnant, lactating, and some control non-pregnant individuals who were receiving COVID vaccination. And then we quantified the titers of SARS-CoV-2 antibodies in response. So we had a blood draw prior to the vaccination, after the first dose, and after the second dose. We also quantified the levels in breast milk and cord blood. We compared these titers to those in 37 pregnant individuals who'd had prior natural COVID infection. And there were 10 women from the initial study who delivered in the time period of this initial study. We also surveyed pregnant individuals and assessed their post-vaccination symptoms via a questionnaire. So reassuringly, we saw that pregnant individuals and lactating individuals made antibodies similar to non-pregnant individuals after both the Pfizer and Moderna mRNA COVID-19 vaccinations. There were significantly increased antibody levels post-vaccination compared to natural infection, which is shown here in yellow, suggesting that the response to the vaccine was more robust and durable than that to natural SARS-CoV-2 infection. And when we compared the vaccination type, at this time it was just Moderna and Pfizer, we saw that both vaccines induced a robust maternal antibody response. The question was also then, will infants be protected after maternal COVID-19 vaccination? And we were inferring potential protection by the presence of antibodies in the breast milk and cord blood. So we saw antibodies in the breast milk of all individuals who'd received vaccination. And we also saw that there was antibodies in the cord blood of all individuals who had been vaccinated as well. And this timing of maternal vaccination matter. So at the time that we did this study, all of our pregnant individuals had been vaccinated who delivered had been vaccinated in the third trimester, but there had been individuals who were in each trimester of pregnancy who'd been vaccinated, and we saw that regardless of the trimester of vaccination, there was a good antibody response. So the vaccine was effective regardless of what trimester of pregnancy an individual was in. And what were the side effects? So side effects in pregnant and lactating individuals were similar to those who were non-pregnant, with the most significant side effects after the first dose being injection site soreness, and after the second dose being fatigue, muscle aches, headache, and injection site soreness, and some fever, similar to the rest of the population. This was not a part of our study, but some reassuring data that came quickly after the CDC had been monitoring through their V-Safe registry who was pregnant and receiving vaccination and following outcomes in pregnancy. And through this monitoring, no safety signals were seen during the first 3 months of vaccination, and still to this day, there have not been any safety signals seen. There was no increased risk of fetal loss or adverse pregnancy outcomes, including preterm birth, congenital anomalies, or small for gestational age. And this is ongoing monitoring for this population. So based on this safety data and the data about the effectiveness of the vaccines and potential protection for the neonate from vaccination, the CDC, SMFM, and ACOG all recommended the vaccine in pregnancy and lactation as of, as of August 2021, or the very end of July. And you can see these statements from ACOG and SMFM and the CDC at these links here. Now, questions have obviously come up recently about vaccine boosters, especially for pregnant individuals who were vaccinated at the very beginning of vaccine eligibility. In October of 2021, the CDC has recommended a Pfizer booster, a third dose, if you've been greater than 6 months since the completion of the initial 2-dose series, for the populations that are older than 65 years old, or if you are in a vulnerable group, either by medical condition or living situation. And so pregnancy is included in that group. And so we have pregnant individuals now receiving booster doses. And you can see the recommendations from the CDC here at this web link. The FDA has met to evaluate the data for both Moderna and Johnson & Johnson, and has recommended that boosters are given for these individuals as well. And we anticipate recommendations following from the CDC soon. So the summary of vaccination in pregnancy is that COVID vaccines are effective in pregnant, lactating, and non-pregnant individuals. We think there should be some protection conferred to infants by maternal vaccination because we see antibodies transferred to the cord blood and breast milk. The side effects are similar in all groups of patients, so there's not more side effects in pregnant and lactating individuals. And there's been no safety signals seen to date, so the data suggests that these vaccines are safe and they are recommended during pregnancy at any time in pregnancy by the CDC, SMFM, and ACOG. Now, there's a lot of vaccine hesitancy among pregnant individuals and women of childbearing age. There's a myth that has spread about infertility associated with these vaccines, which is a myth. The vaccine does not affect fertility, although there's increasing evidence that having COVID-19 can affect fertility and reproduction in both female and male individuals. But studies have explicitly been done now on pregnancy rates, IVF performance, and sperm parameters in individuals who have received the COVID-19 vaccine, and there is no effective vaccination on these parameters. So if individuals are attempting conception, there is no reason to avoid having the COVID-19 vaccine. And you can see an excellent summary of the data in this recent Scientific American publication seen at the link here. So what are counseling points if you're trying to convince a pregnant individual to be vaccinated? I would say discussing the high risk and increased risk of severe maternal morbidity and mortality in pregnancy and the importance of being protected from that infection. COVID-19 also increases the risk of adverse pregnancy outcomes, such as preterm delivery, hypertension, and hemorrhage. So having COVID-19 in pregnancy is dangerous. Having the vaccine is not something that we've seen to be dangerous. And actually receiving the vaccination will provide some protection to your infant, and both via passive immunity, so placental transfer and breastfeeding. Two very helpful reviews for reference are this COVID vaccination in pregnancy and lactation review, as well as this COVID-19 in pregnancy review, and I'd highly recommend reading them for a review of the literature in both of these areas. So this work from our group has been possible due to a large number of individuals that are acknowledged on this slide: our MGH group, our BWH group, the Lee Lab, the Ragon Institute, and Alter Lab have done very important aspects of the work that we've contributed to what is known about this, and many others have contributed to the important science in this area since the start of the pandemic. Thanks so much for your attention. PBS Nova also just released this episode about COVID vaccination, which you can see here. Thanks so much for your attention, and we'll take any questions.